So here, the patient told us he started about 3 years ago with syncopal episodes. Some of these episodes triggered falls, provoking head trauma in multiple occasions. This happened 2 or 3 times a week, and the loss of consciousness was transitory, and it was related to simple visual hallucinations and vertigo lasting less than 1 minute. So the man had a history of hypertension under treatment with angiotensin II receptor blocker with losartan and an loop diuretic with furosemide. So during a physical exploration, the otoscopy was unremarkable, but the tuning fork test in 512 Hz was compatible with right side sensorineural hearing loss. The pure tone audiometry yielded results compatible with right side severe sensorineural hearing loss as shown in the chart. As we can see in this image, the pure tone audiometry, we can see significantly better results in the left ear on the right side of the screen, in this side, than in the left side of the screen. So the last left side has a pre-existing hearing loss, but the pattern on the right side, along with the time of onset, is compatible with sudden sensorineural hearing loss. We also can see the speech audiometry, and it reveals a much more difficulty in speech comprehension in the right ear than in the left ear, as we can see in this image. So we used Hind's protocol as part of the vestibular evaluation, revealing a spontaneous nystagmus to the left side that didn't change of direction, a positive head impulse test to the right side, and unaltered test of the skew. So these results were compatible with peripheral vertigo, a secondary to right vestibular lesion. So we also, nevertheless, we realized during the exploration, physical exploration, that we found some symptoms that were incompatible with peripheral vestibular lesion. First, the amplitude of the nystagmus didn't change, which changes the direction of the gaze that typically happens in a peripheral lesion, according to Alexander's law, which states that the nystagmus amplitude will increase when moving the eyes in the direction of the fast phase, and it will decrease when moving the eyes in the opposite direction. Second, the amplitude of the nystagmus should decrease when fixating gaze in a peripheral lesion, and the opposite happens in this case. In addition to this, during the positional maneuvers, such as this half-back roll test and hyperextension test, the nystagmus changes the direction in a different manner, as would be expected for a patient that has coexisting a benign paroxysmal postural vertigo. So on the other hand, a short direction dose reduction of oral prednisone scheme was initiated to treat the sensorineural hearing loss. So considering the inconsistent results in vestibular exploration and the history of the multiple syncopal events, we solicited a cerebral magnetic resonance imaging to perform on the patient. So this magnetic resonance allowed us to discover a vertebrobasilar dolichoectasia at the level of the right vertebral artery in the V4 segment, just right here. So a generalized reduction of the cerebral parenchyma was also observed, along with hyperintense lesions in T1 sequence and a hypointense in FLAIR, of heterogeneous aspect on both sides of the frontal lobe. These last ones are possibly secondary to bilateral hematomas caused by a history of head trauma. So here we can also find images compatible with cellular arachnoidocele, just right here. So a carotid vertebral Doppler was performed later. This allowed us to further confirm a right vertebral dolichoectasia, just in this image. The patient returned to our service 2 weeks later after completing the oral steroid scheme, and a new pure tone and speech audiometry were performed. In this second test, we can observe a partial recovery according to Sigel's criteria with a PTF after treatment of 43 decibels. And speech audiometry also showed an important improvement as the patient described himself. Currently, the patient is still under vigilance by neurology, audiology, and neurotology. So we can define the dolichoectasia as the abnormal dilatation, elongation, and tortuosity of arterial vessels, and is it not common with a prevalence of 0.05 to 0.06%, and the vertebrobasilar circulation is the one that is most frequently affected. So the vertebrobasilar system is the main circulatory system in charge of delivering oxygenated blood to the inner ear and the cerebellum. From this system is where important arteries such as the anterior inferior cerebellar artery comes from. So as we can see in this image, the labyrinthic artery emerges from the anterior inferior cerebellar artery, and this artery divides in a vestibular and in a cochlear branch, as we can see just right here. Giving the inner ear the blood irrigation that it needs. So it is important to point out that unlike the other parts of the body, the inner ear does not have a collateral irrigation system, and because of that, any kind of compromise of this circulatory system can greatly affect the inner ear and the cerebellum. Some of the symptoms we can expected in ischemic events in this region. It can include cerebral compromise, such as instability, diplopia, ataxia, dysarthria, vertigo, and dizziness. Audiovestibular compromise with hypoacusis, tinnitus, and vertigo, and the brainstem compromise as the transient loss of consciousness caused by affection of the ascending reticular activating system. So many neuroimaging studies are not capable of diagnosing small cerebrovascular events in the posterior fossa, reporting up to 50% of false negatives. It is similar to what happens with transitory ischemic attacks, making it many times impossible to observe the affected region. Nevertheless, it is very important to make a correct diagnosis on patients with affection of this region, because the risk of the ischemic stroke increases threefold on the following 4 years in patients that had vertigo as only symptom in a posterior ischemic stroke. This is why in our service, in our medical practice, we use the HINS Plus protocol to make a differential diagnosis between an acute peripheral vestibular syndrome and a central one. HINS Plus is a diagnostic tool with a sensibility of 99% and a specificity of 97%, making it in many instances much more useful than a magnetic resonance. It is an acronym of a series of symptoms: HI, head impulse test, and the characteristics of the nystagmus, and the TS, the test of skew, and the presence of the unilateral hearing loss as in the is the plus. So as we can see in this video,
Go nice and loose.
The head impulse test is a test very useful tool that make use of the vestibular ocular reflex to evaluate the integrity of the peripheral vestibular system, and it is a neural pathway. As we can recall, the vestibulo-ocular reflex has the objective of stabilizing gaze via compensation of head movement um, of the head movement and the movement of the striacular muscles in a way that the images we see can remain stable regardless of the head movement. The neural pathway of this mechanism travels initially through the vestibular nerve, passing through the vestibular nuclei and finishes to the motor neurons, to the extraocular muscles, in a way that every plane of the movements is controlled by a different semicircular canal, the macule or the utricle. Because of this, the normal response in a patient without a vestibular pathology is that the eyes move in the opposite direction and the same speed that the movement of the head. Meanwhile, in a patient with a vestibular affection, this reflex will abolished or diminished in such a way that when the head movement is initiated to one side, the patient will not be able to move the eyes at the same speed, and therefore we will find corrective saccades, as we can see in this patient. Yes, so we also, on the other hand, let's remember that the characteristic of the peripheral nystagmus would be nystagmus that decreases in amplitude with visual fixation, and the opposite response with gaze inhibition. The nystagmus should increase in amplitude when the eye moves to the side to the fast phase, and decreases in amplitude when the eyes moves to the side of the slow phase, according to Alexander's law, as we can see in this video. In addition to this, the direction of the nystagmus should not change depending on the direction of the eyes movement. Furthermore, the direction of the nystagmus should not change with head movement in a direction other than expected in a patient with VPPV. So, in the test of skew is a test that we can observe a vertical deviation of gaze that can be explained by palsy of striacular muscles. This reflex is useful to keep a fixated image in the retina when the head movements when the head moves to one of the shoulders, resulting in a oblique eye movement from contralateral hypotrophia and ipsilateral hypertrophia associated with a bilateral cycle traction. The neural pathway for this gaze fixation would be the same as the BOR. However, in this case, the neuron of the vestibular nuclei in the protuberance will send the information to the medial longitudinal fasciculus in the mesencephalon. So the lesions of the pons of mesencephalon can provoke an altered test of skew with a vertical deviation of gaze, as we can see in this video. Yes? Okay. So as the in summary, a Hines plus test will be considered dangerous when any or all of the following are present. When the head impulse test is negative, then nystagmus has not peripheral characteristics, and the test of skew is positive, and there is a presence of hearing loss. The presence of unilateral hypoacusis can confuse the diagnosis with a peripheral pathology. However, in the case of infraction or transitory ischemic events in the ICA, it's frequent to find vertigo associated with hypoacusis of mixed origin. Something worth mentioning is that the head impulse test also tends to be positive in these cases because of the damaging effect that the interruption of blood flow from this artery has in the inner ear. So Among the findings, we found correlation between cellular arachnoidocele and cochleovestibular disorders. One of the most relevant studies regarding this phenomenon was made by Boliaga and Guzman, who found that 40% of patients with cellular arachnoidocele experienced vertigo. In summary, we consider this case a mixed-cause vertigo associated to a sudden unilateral hearing loss, likely secondary to a posterior circulation abnormality and an empty cella Turkica syndrome. Despite the fact that sudden sensorineural hearing loss caused by ischemia of the vertebrobasilar system is rare, it is very important to take it into account, particularly in patients with bulbar symptoms associated with sudden hearing loss and a spontaneous vertigo. Thank you very much.
Thank you so much. Thank you so much for the excellent presentation. Is there any question for her? Now, without any question, thank you so much. And I take this opportunity to thank all of the speakers and attendees who made this event a success with their eminence and presence throughout the day. We hope to meet you all of you tomorrow for more exciting and thought-provoking research work from several other eminent persons across the globe. So even though you have done your presentation today, we expect you to join us tomorrow to continue listening to the presentation of others, and so that we can continue learning from each other. Otherwise, with that, now I will say, wherever you are, the time which is your time, others is morning, others is evening. In Kenya, it's around 7 p.m. So as we are almost going to sleep, thank you so much, and have a good, a wonderful time as we continue and proceed with the conference.
Have a good day. Yeah.
Thank you.
Very much.
Thanks, Susan.